So we'll be going to this case now. This is a 46-year-old male with a history of 10 bowel movements per day for a decade. He underwent an initial average risk screening colonoscopy and was found to have burnt out ulcerative pancolitis with pseudopolyps and a 2 to 3 centimeter flat lesion in the cecum and rectum, which were biopsied and came back as tubulovillous adenoma and an inflammatory polyp with atypia concerning for low-grade dysplasia. He was started on mesalamine with improvement in symptoms. Okay, we're live. Hello.
Hey, hi.
Hi, Hazem.
Hi, Sachin.
How you doing?
Okay. Doing well. Thank you, Sachin. Hope things are going well in the auditorium as well.
Yes.
We have this patient. We actually did a full colonoscopy before you guys were able to join us. And actually in the cecum, the report was a little bit not clear, but the cecum was actually clear. It may have been a small little polyp that was removed, but we did a high definition white light examination of the cecum as well as narrowband imaging examination of the whole cecum. We could not find any well demarcated or abnormal areas in the cecum. So we did not do anything. But we came to the rectum here and just about 7 centimeter from the anal verge, we see this sessile lesion. And we talked yesterday in the lecture how to evaluate these superficial colonic neoplasia. So this is what we would call 1S lesion or sessile. Size-wise, it's about 2, maybe 2.5 centimeter. And if we look at the pattern, we can clearly see this nice 2 pattern throughout, indicating an adenomatous tissue with no amorphous pattern to suggest deep submucosal invasion. In ulcerative colitis, the EMR just gets a little bit more interesting, or just chronic colitis in general, because people are still using that DOM term, and we should not be using these terms anymore in 2022. I think we should, if we see a lesion in ulcerative colitis, we will look first to see if the margins are clear and well demarcated, and if this lesion is visible completely with distinct margins. So that's how we will basically distinguish dysplasia in IBD. Is it visible dysplasia or invisible dysplasia? That's the other thing to look at is there any superficial ulceration as well, indicating also inability to resect this area. I think I don't see anything concerning on this lesion. I see very nice clear borders. I have Dr. Jeff Eastler here with me in the room. And I think you can approach this area both ways. We talked about doing an ESD or doing an EMR. What do you think, Jeff?
I think both of those are possibilities. We were just discussing kind of your thought process, and you thought ESD was something that should be given consideration because of the fibrosis in the setting of chronic inflammation. Can you expand on that just a little bit as to why that's an important part of your decision making with some of these lesions in patients with inflammatory bowel disease?
Yeah, I think these lesions can be really difficult to manage in the setting of chronic colitis. And if the lift is not adequate and you're dealing with a lot of submucosal fibrosis, then ESD and just slow dissection of these lesions from the wall using the ESD knife is a better approach. We tried actually with the kind of like the worst looking areas from fibrosis standpoint here, and you can see we got some lift. So I think either approach is adequate with just the tubular adenoma and no high-grade dysplasia or carcinoma. I think if we can get good piecemeal resection with cautery, snare tip, soft coagulation of the resection margin, I think that would be adequate too.
So one question I have for you is whenever you do these cases and you're maybe testing with the lift, do you burn any bridges by doing injectate from an ESD standpoint? Does it
Yeah.
make, if you change your mind or somebody tries to take this off and they lift it at first,
This
does
is
that create any fibrosis?
Yeah, great question, I think, Jeff. One thing that I would ask my colleague to do is not to take extensive biopsies from the lesions if they are thinking about referring this case, not to tattoo under this. And also, if they want to test it for lift, like just to check the lift sign, is only inject saline and nothing like Orize gel or any other gel substance, because that can cause fibrosis as well and make the a future procedure harder. We're going to proceed with injection here. We have injection of an Orize gel here.
Awesome.
And from the yes.
Yeah, Hazem, I just wanted to tell you that we have another room that's ready. If you can just demonstrate lifting, then we can move to Dr. Athman's room. Hazem, can you talk to us a little bit about your technique to perform submucosal lifts?
Sure. Yes. So I have the needle here. Some people put the needle deep into the tissue and pull back. I just get inside the submucosal space, inject these. And then what I do is I suction, I pull back, I go up and suction the lumen, inject, hard and fast, stop, needle back. So with this, we call this a dynamic submucosal injection. So we are moving the scope tip while we're injecting. As you can see, even in a fibrotic patient, we're able to get a really neat lift here. So suctioning the lumen and moving the needle back and moving the scope tip in the direction of the lift that you desire. Needle out again. Inject. Okay, go ahead. Same thing here. You can see I'm moving my scope. I'm suctioning the lumen in that desired directions. Up, needle back. Okay.
That's great.
And as I always say, you don't have to lift the whole lesion at once. Sometimes it's just a stepwise process. Just go slow. We're going to actually cut the first piece of this lesion and then continue this process of injecting and cutting.
Hazem, before you cut, we want to show what's happening in Dr. Athman's room. So can you just hold off on that first resection, please? Let's go to Dr. Athman's room, please.
Thank you.
Thank you.
This next case is an 81-year-old male presenting with intermittent melena and iron deficiency anemia. He underwent an upper endoscopy at an outside hospital, which revealed a 5-centimeter polyp in the gastric cardia. The polyp was biopsied and returned as a tubular adenoma with low-grade dysplasia.
Hello.
Hello.
Hi, this is Mohammed again. Are you hearing me better this time? I hope.
We're doing great. We're very eager to see what you've been up to.
Mohammed, thanks for being so patient.
No problem at all. So we have a lesion here. It's very vascular. The patient actually, before the procedure, told me just he vomited blood. So it is extremely vascular. It's similar to this one here. And he had another one that they removed in this area. Although the pathology looks like tubular adenoma, to me, this is more like granulation tissue or hyperplastic polyp. But it's very broad-based and very friable. So what I did, I cut first with a knife to allow to have a groove for the polyp. But as you can see, the location will make ESD impossible because you cannot go all the way around. In Japan, they will have something called double bend scope for that. So what we're going right now that we'll try to, and we're using double channel endoscope, and we're going to try a method, see if it will work or not. We will get the snare. Let's open the snare. And we'll advance the raptor through the snare. So now I have my snare around the raptor. Let's close the snare, but not completely. You don't want to close it so hard because I want to get the raptor to work. And then we'll try to see the lesion. Open the raptor. We can get the raptor open. Yeah, thank you so much. Now close the raptor. And we have to be careful because We have a friable tissue here. I will slowly advance it. Let's open the snare. Open the snare all the way. And then we'll manipulate the polyp inside it as much as we can. So I'm trying to see how deep I can get through it. So I'm now moving my snare down. And the more I move the snare down, I'm pulling it here.
And are you aiming to get to as much of the base or just to get the bulk off at this point? Tell us what your goal is with this technique that you're using.
Actually, I'm aiming to get as much as I can toward the base, but you can see here it is difficult. So I will get what I can do. I will end up debulking it. Having said that, I didn't load the hope yet, that I can just do it. So right now, if I do it, it will be debulked. If I go this way a little bit, let's try to close the snare slowly, slowly. All right. So now I think we got a little bit. We still have part of the phase, but that's not bad, whatever we got. For now, open the snare a little bit. Let's try to go down more, close. So in this situation here, because of the bleeding, I better cut what I have, and I'm going to use force coag. So I'm not going to use endocut because of the bleeding. And with that, we got the first piece open. Close. So we
And
got
this
one piece
debulking
out.
technique, do you use, or what's your threshold based on whether you think this is a benign lesion versus a neoplastic lesion? Can you speak to that?
Yeah, so if this was really high-grade dysplasia, this technique wouldn't be enough. But what I'm seeing here is inflammatory polyp, and I saw other inflammatory polyps. And I had the situation before that these polyps could look like low-grade adenoma when they are that large. And even if it is low-grade adenoma and we don't have a sign of cancer, we can do a piecemeal. But definitely, if this is positive for cancer, he will have to go for surgery. As you can see here, we don't have a lot of space to do even ESD or even good EMR. Like the location that they call is a perfect location, just in the red section. So I will remove this piece.
We're going to come back, but we have to hop over to the other room real quick, and then we
Sure.
are going to be back to you. Okay,
All
we'll
right.
be back. Okay, we are back.
Not me back.
Hello.
Okay. All
So
right.
Hassam has just done a little bit more injection of the lesion. He's getting a very good lift here. One thing we were discussing is snare selection. Could you speak to that a little bit in terms of size and
Yeah.
aspects of the snares that you like to use for these EMR cases?
Yeah. I think, thank you, Jeff, but I think as Satyan was alluding to, like the lift is really important, the technique of the lift. Even in a scarred area like this, we're still able to get some really neat submucosal lift with the good technique. Jeff was asking about the snare. I mentioned something in the lecture yesterday that if you're curious about doing endoscopic resection, you have to use the stiff snare. Open slowly. This is a 10 millimeter stiff snare. You guys can see the design. Come back a little. That's good. Perfect. The more soft snares, they're really hard to get around lesions and be able to dig deep into the submucosa. So slowly, we're working very close to the scope tip. We're adjusting, making sure that we have a good margin, and we're going around this area. And I'm going to push slowly with a little bit of flexion and go ahead and close slowly, Amy. Have Amy Marquisio with me. Go ahead, a little bit more close. Okay. Okay. So we're have a good amount of tissue here. We're going to go ahead and resect it. There's a lot of fibrosis. It's really hard to get to the hub with these kind of patients. So we're going to go slowly with me on the cautery. 1, 2, and 3. Go ahead. Good. Okay. So we have the first bite, and sometimes with the first bite, your intention is just to go into the submucosal space. Perfect. Always assess that resection site.
So
Perfect. A lot of
for-
fibrosis.
For patients who
But it
have
looks
these
good.
lesions in the setting of IBD, is your approach to use cautery as opposed to cold snare polypectomy?
I think the patient session, I think more and more we're, the cold revolution, as some may like to call it. We use it for sessile-serrated adenomas now for all the time. But even for these soft, polyps, tubular adenomas, you could think about using this. But we thought with this, because of the fibrosis, it's going to be really hard to cut. Go slowly, please. You good? Good. Excellent. Okay. So we're just going to continue with this. Close more. Cut with me. Good. Okay.
For the folks in the audience, maybe you can speak to your decision to use a 10 mm snare rather than using a 20 or a 30 mm snare or a large snare.
Were you asking?
The amount of fibrosis can be really, really, bad with these patients, and you have to do multiple injection.
Mihir,
That's
what's
why
your
sometimes-
approach to these lesions
So,
in the setting of
Um,
IBD?
so I'm
E-
always concerned about fibrosis, so I tend not to use big snares. I think that's when you can get into trouble. So I think just patiently working with the smaller snares and working, because smaller the snare, less chance you're going to cause a perforation, and if you do, the smaller the defect is going to be. So I think smaller snare is what I'd use.
And do you tend to use cautery versus cold snare polypectomy?
Cold if I can, but then many times with
Needle out.
fibrosis, you may not be able to cut through, and then
Sure.
I will use
Inject.
cautery.
So you do it on a case by case basis?
Correct.
Now needle back. This is all fibrosis here, as you guys can see in the submucosa. Go ahead and use a snare. So just patient and slowly getting in, all this lesion out. Certainly this, many, many days, and I think it was just getting late into the day, and that I would have chosen to do an ESD, particularly if there was high-grade dysplasia on the pathology or concern for carcinoma. And that also would have been a good option for this patient. Open slowly.
Hazem, we're going to move to Raj's room. He has something exciting to show
Okay.
us. So let's go to Dr.
Perfect.
Shah's room, room 14, and if we can have the
Thank
case
you.
presentation. Thank you,
Go
Hazem. We'll
slowly,
be back.
please. Thank you.
It's looking pretty good so far.
You got some? Oh, you just schemed over this. Yeah. That's okay. It's all just junk. Yeah, that's okay.
Yep. Hazem, just 1 second. We're about to move to Dr. Shah's room.
Okay.
So for this next case, we have a 65-year-old woman with chronic calcific pancreatitis complicated by obstructive main pancreatic duct stones and genu stricture episodes presenting for further genu stricture dilation and pancreatic endoscopy laser lithotripsy. Patient has required prior pancreatic stent. The last one was 7 French PD stent and stone lithotripsy to date. Recent ERCP in June 2022 showed a pancreaticogram with a 15 mm genu stricture, a stone found at the genu body with upstream dilation and downstream decompression. Genu stricture was dilated to 4 mm. The stone limited the device passage, and therefore pancreatic stenting was performed with an 8.5 French by 9 cm plastic stent to accommodate for future pancreatoscopy laser lithotripsy.
Hello, everybody.
Hey, Raj,
Hello.
Can you hear me okay?
Yes.
loud and clear.
Oh, that's great to hear. So we have a stone. You know, Dr. Deloy, Anna Deloy, had done an amazing job with this procedure because her previous procedure, she had done this pancreatic sphincterotomy, had placed a stent in, upsized the stent. Her symptoms, the patient's symptoms are actually improving. The scalp film here shows the PD stent. Here, get here a little bit. Shows the PD stent right up to the level of the stone. If you can appreciate that, scroll the image. One more. And then here's a wire curled around the stone. Go ahead. And then we're balloon dilating. Keep going. Balloon dilated up to the almost to the stone, but you can't get any contrast above the stone. I want to emphasize that. There is no contrast above the stone. We couldn't do that. Okay, go again. Down there, so we dilate. We have SPY pancreatoscopy in now, irrigate here. And we have lasers set up. And what we wanted to show real quick before you go back to Hazem is this concept of stricturoplasty. Sam and I and others in our group have had some publications on this. Irrigate here a little bit. And what we're trying to do, you can see the stone. I don't know if you can appreciate that stone.
It's beautiful.
And so, but there's a stricture, a very benign looking stricture that we're going to use a soft tissue setting, irrigate here, to try to just do just a minimal stricturoplasty. Irrigate here. And what we're trying to do is just open up the duct just a little bit more to improve position for cutting. So I'm trying to get from distal upstream to downstream, and we're splicing, irrigate here. And basically we're just ablating fibrotic tissue. And we were the first to really describe this concept of stricturoplasty into pancreatic duct, irrigate here. And the idea is really to try to treat strictures. Maybe this is alternative to long-term stenting. We don't know all that. We need a lot of more data on it. But in this case, we've been utilizing it to try to improve scope position. Now you notice that I'm trying to, I don't know if you can see my hands, but I'm trying to irrigate here, get to this upper part of the duct if I can. And it's hard. Once you have a device in the SPY scope, it does reduce your ability to tip deflect or tip articulate. Is there some background noise? Can you guys hear me okay?
Yeah, we can hear you fine.
Raj, we're just
I
intrigued
hear
by
like
what you're
another
doing.
room or something. What's that?
I said we're just intrigued by what you're doing.
Oh, okay.
We're
okay.
speechless.
Here. I hear some, okay. So there we go. So you try, when you're using laser, you try to get the blue, the coated portion a little bit outside the SPY scope to reduce damage. Irrigate here. And so this is a second quadrant I'm trying to get at. Ideally, I try to get a third quadrant. It's not much pressure. You don't want to cut too deep. Our settings, the soft tissue setting is 0.8 joules and 5 watts is a total of 4 watts. It doesn't take much in the PD. Our urology colleagues probably use higher when they're ablating. For urology colleagues, Miranda's back here from the laser company. I have Christy here, Tronic, and Michael somewhere is around me. So Dr. Hahn behind me, irrigate here. He doesn't like being behind me during procedures anymore because his training is completely done. But he gracefully agreed to stay behind me for this case. Irrigate here a little bit. So we have this, the green light is actually not the laser. That's just the light, what I call the aiming beam. And so it's just the aiming beam. So the laser, you'll hear some audible feedback. And do a little bit more here. Okay, irrigate here. And I have learned, we've been doing this for a few years, but I have learned that we don't want to do too much cautery. The pancreas duct doesn't like cautery. It's not so much for pancreatitis flare-up. I've seen a couple cases where the stricture actually gets worse after laser. For the most part, we use it to treat the stricture, but if you do too much cautery, it becomes much more difficult. Now we can target the stone better, irrigate here, and we're on stone busting. The stone busting is 1 joule, 12 hertz. I think that's a reasonable start. And we're going to go ahead and that's the main thing I want to show you. I don't know if you want to see this part or you go to the EMR, irrigate here.
No, we want to
But
see
we'll
this.
just, okay, well, you don't have to stay for the whole time. I don't want to take away from that EMR, but I'm just going to cut. I'm just trying to stay about 1 millimeter away from the stone. And because if you touch the stone, sometimes you get a hole. I mean, you can just create a hole in the stone. So we're just doing a sterile saline irrigation. Antibiotics have been given. But that stricturoplasty was entirely necessary, in my opinion. Why? Because I think that it improved the space to try to do the tip articulation and improve positioning for stone fragmentation. And then you can start seeing, the laser technology is really dehydrating the stone. So it's a rapid expansion and collapse of this, of these electrons. And through the aqueous medium, it creates a shock wave through this energy. It's very precise, so that can be advantage and disadvantage. The advantage with the precision is that it can be faster if you have good position. The problem is that where EHL can be more favorable is that if you have the EHL fiber off to the side, you can still cause fracturing of a stone. But I think for pancreatic duct stones, which are mostly calcium, that we have gone to prefer laser for this. And then Sam, I'd love to hear from you and your opinion regarding this technique, but also about what you think about SBAL in this setting. And I'll go ahead and ask that question before the audience would or the moderators.
Yeah, so in the US, SBAL is kind of a limited commodity in that a lot of times it's urology directed and few gastroenterologists are trained in it. And so we have less access to it. But when you do have access to it, it is pretty good for stones that are in the head and genu primarily. Obviously, radiolucent stones, it's not great because you can't see the stones unless you have a stent to guide you in terms of where you want to perform the lithotripsy. But this is a great case of where ESWL probably would not be effective because there's still a factor that you're not able to treat with SWAL. And so by doing ERCP and pancreatoscopy guided lithotripsy and laser stricturoplasty, you're able to treat the stone and the stricture at the same time. So if you had done just SWAL, you might have fragmented the stone sufficiently, but those fragments probably would have stayed there. And again, the patient is at risk for developing recurrent stones afterwards.
Yeah.
But I think it's a great question to answer with a randomized study. Don't you think, Raj?
So we are, Sam and I, it's Sam's protocol. I just happen to be at the right place at the right time. And we have how many sites, Sam?
8 sites.
8 sites. Do you want to describe it a little bit?
Yeah, so we're doing a multi-center randomized trial. We're really really what
Sam, you cut out. We can't hear you.
Sam, can you speak up? They can't hear you.
EHL and laser lithotripsy for pancreatoscopy lithotripsy. We're basically allowing 4 sessions for each treatment arm before we consider it a failure. And we're allowing crossover as well. But it'll be good. In Europe and Asia,
very good.
Raj, I almost saw the scope go past the stricture there.
Yeah, I did. We're past it. We're kind of in and out of it. And I think, Sam, what's your opinion about SWAL in this setting? Because we have a very tight stricture that we're unable on 2 occasions to get a stent across or even contrast across. And if you did SWAL on this, what do you think?
Raj, can I ask you a question about the stricturoplasty?
Yeah, Sam is used to repeating himself. He's worked with me before, so apologize for that. Oh yeah, go ahead.
So when you were slicing the scar tissue, do you have a typical approach in terms of how many quadrants you want to cut into?
Should we turn it up?
Do you do 4 or 6 incisions? What's your typical approach to that?
I try to do in 3 quadrants, ideally 4, but it's hard to get a 4th quadrant. And so I will do gentle pressure starting at about 4 watts, which is what we did. And then, can you hear me over the lithotripsy?
Yes.
Yes.
Okay. And then, yeah, so now we're well beyond the stricture. So we start upstream to downstream. And then the number of strokes, it depends. It's sort of like needle knife, like you start with superficial layer, you don't feel like you get much effect. And just like with needle knife, right? You can't take away, but you can keep cutting. So I kind of approach it that way. I don't know if that answered your question, Sachin.
That was good.
So we're gonna keep breaking this up a bit because these fragments are too big to remove. And we're beyond the stricture now. Nice. Oh, that's good. That's really good. Okay. Now you may see that the laser fiber, this glass tip, it's a little close to the tip of the spice scope. I would not recommend that you do this. It's just kind of stuck. Like I can't get it to advance any further. I've unlocked my, the wheels on it and I'm trying to advance it. But I think, you know, sometimes what happens is you get stone fragments in the working channel. And if you get stone fragments in the working channel and you have a device there, then it's harder to maneuver it in and out. I'm just worried that if I pull it back, it'll have a hard time or it'll be impossible to push it back. So I'm taking a little bit of a risk, not to the patient, just to the device. I just want to emphasize that. No risk to the patient, but there is some data from Sandeep Patel. I think, Sam, you're working on getting that published. Sandeep Patel from UT San Antonio. There's an animal model, porcine model, looking at how much laser you can apply to a porcine bile duct without causing perforation. And any guesses from the panel as to how many seconds you could place in a porcine bile duct, how many seconds you could have it on a bile duct and not cause perforation. Any guesses? How many? Oh.
10.
All right, maybe that wasn't a very interesting question, but it's about 5 seconds, up to 5 seconds. So I'm not saying that you would use a laser fiber to
Raj,
do
Paul-
that,
Paul
but I think
did
there's a
say 5
safety
seconds.
profile with this laser compared to EHL. Having said that, I've had ductal perforation with laser. I've had it with EHL. It happens. It can happen. It's rare, but it happens. And you have to be prepared to deal with the recognition. You got to recognize it and then treat it. And treating it is putting a stent across. If you can get a stent across, then you're pretty much good, golden. And now we're up the duck here. Look at that. You just have to be able to manage the adverse event. That's all I'm saying.
Raj, I didn't know that answer to your question, but I just envy you because like in Austin Powers, you get to fire the laser.
Sorry, what was that? I missed it.
Never mind.
Oh, Sam was asking, what was the question, Sam?
On or off while you're performing.
No, I'm out.
So,
No,
so
I keep my suction off.
Raj, can
Yeah.
you tell us what your next step is going to be? Are you planning on dilating that stricture,
Yeah, a little
showing us now contrast above the stone?
I think we have a 10.3 French device across it. So I don't think we're going to dilate it. We did stricture. We dilated before.
Got it.
But, oh, I see what you're saying. Dilate it again. Yeah, you're right. Maybe I should. Because
Okay.
usually with stricturoplasty, we do a little bit of cautery and balloon dilation. So I like that. So we're going to balloon dilate that area again once we get the wire up. And then we're going to get a stent out to the tail. And I already told her that we'll break up the stone, hopefully. But the ability to try to remove all the fragments in one session is really not feasible. That's not practical. So we'll stent across it. Hopefully that'll lead to more improved pain management for her. And then we'll bring her back in 6 to 8 weeks for continuing this treatment.
That's fantastic, Raj. A lot of credit needs to be given to Dr. Shah for actually being so innovative and using this technology to manage a really tough patient population. So congratulations, Raj. We're now going to
That's too kind. Thank you.
we're going to move to Dr. Atman's room, room 15.
I can't.
Hello, we're back.
Hello. So we're almost finishing here. We're just in the last piece of the lesion.
And so
When
tell
we're
us what
doing
you've been doing. You've been
endoscopic view.
debulking from the, have you had a direction that you've been working with or just going with
Yeah,
whatever
so
comes?
basically we removed all the large parts we can show it to you. And now we're getting all the way down. And you can see here, it's not a pretty work because we have a lot of blood, but you can see the base here and there and here.
So tell us a little bit about the tips and tricks you're doing, because I see that your position is retroflexed and you're working in a retroflex position, almost unbossed. So trying to get the snare in a tangential position would be of some technical difficulty. Can you tell us a little bit about the technique you used?
Yeah, so basically, it is a coordination between me and my technician or nurse, and she's doing an amazing job. So basically, we're gonna remove this upper part now, and we're gonna highlight that technique. We'll open the snare on the left side around 11 o'clock, little bit by little bit. So let's open. And then we'll try to use the tip of the snare. It didn't work that side, will work in the other side, and just go around the tissue. And now it is open enough. This is not open all the way to the end. So try it again, close completely.
Yeah.
So yeah, you want to open just enough to get the tissue. So let's open the snare. I will hook it there, open a little bit more. And once I get the desired opening, I will tint my scope to suction the tissue here. And then my technician will have to close slowly. So start closing, slowly, slowly. Beautiful, you're doing great. Good job. You're snug now. All right.
What
So now-
snare are you using for this?
We are using a spiral snare. What's the name for it again? The 20 spiral. Yeah, Olympus spiral snare, which is good for this situation.
And,
So I feel right now we got the. Yes, go ahead.
and previously you injected the whole base with ORISE or?
Yes, we did ORISE for injection previously, and you can see that there is still some blood vessel that's bleeding here. Let's get the tip of the snare and go to soft coagulation. Yeah, 5 and 50 is okay. And then we'll just go soft coagulation here. I still have some tissue around it, so it's not gonna work perfectly. All right, let's clean the snare. So overall, I know this type of lesion. I will be surprised if this comes back as tubular adenoma. To me, this looks like granulation tissue. It's the same like this one here. We have another one closer to it here, and they grow large to look like this one. The only problem with this one is just it came in a tough location that's very hardly seen. But I also learned if you leave any residue, they grow back and come back in 2 years with another polyp. So that's why I'm trying to remove all the base. So I still have a little bit small piece left up in that corner, and that is the toughest corner, the one usually in your left when you're on retroflexion. If that snare doesn't work, I'm gonna go to 10 millimeter snare to get that piece that's left. Open. Yeah, that's a little bit. Okay, yeah, a little bit more. Let's open more. Yeah, I would open. Yeah, let's open to remove this part. So open more. Yes, good. So I'm not able to get into that position easily. So I'll try. I can utilize whatever I dissected, open more, but it's such a small area. It's a little bit more. Yeah, this snare is not going to do it because it's too small, too big for that area. And this area is too small. So I will avoid using that snare in that particular area, and I'll use 10 millimeter snare. Because in retroflexion, if I put a lot of pressure on the pulpectomy bed, we can have a perforation because the muscle in this area is not that strong. So the next step would be to use a 10 millimeter snare, and you just go on fast against it.
Mohammed, as you are getting a new snare, we're going to jump over to Dr. Hamad's room. Let's move to room 16. Hazem?
Yes,
Hey, how you doing?
doing well, Sachin. As you can see here, we are done with the resection here. We have quite a bit of oozing, but we were able to resect the lesion completely. And we did as we talked about yesterday, soft coagulation on the edges of the resection. We also treated some of the base here as well, some of the oozing, small oozing vessels in the base. But we have a really good control on the lesion here with no residual, at least macroscopic or gross residual of the adenoma. So I think we feel good about the resection. What do you think, John?
Yeah, I think it looks great. I think certainly we don't see any residual lesion, and looks like you're able to get good hemostasis here, with a combination of epi injection, creating a cushion,
Yeah.
so you can deliver soft coag
What do you typically,
for hemostasis.
what do you typically do for follow-up for these patients?
Yeah, I mean, any piecemeal resection, generally 3 to 6 months is our approach, and that's what we will do for this patient. These patients become really hard to, close with the clipping because of the fibrosis. And I think the best thing would be just to get some good hemostasis and leave it without any further clipping. Any thoughts, Jeff?
Yeah, I think if you tried to fire clips on this, I think it would slip right off the edges. It's very stiff. You also have the injectate there, which I think is going to make it even more difficult. So,
Yeah.
yeah, I think clipping may work against you. You may scrape that clot off there.
We'll take that, snare
No, I
clip,
think
the
clipping would
snare.
be very difficult here.
I think too, most of the evidence to support clipping is in the right side of the colon and you're in the left side of the colon here. So your risk of bleeding
100%.
post-procedure is much lower.
Yeah. Yeah.
Agreed.
You could argue like that colitis is a special kind of a consideration and the risk of bleeding, but certainly I agree with that. It's probably could cause more harm than benefit here.
Terrific. Awesome.
Cool.
Thank you for a
Thank you,
fantastic
guys.
demonstration.
Thank you.
We're now going to move to room 14 to Dr. Shah, please. Hey, Raj, we're back.
Hey, Sachin, how are you? So we had an issue where the stone fragments were stuck in the channel and I couldn't get the fiber out. So we went and we used the back end of the wire to kind of, and carefully, of course, but we just pushed through the channel of the spicescope, and that was able to then allow us to feed the laser fiber through again. So we're at the same laser fiber, and we're just doing a setting here that we were just talking about called dusting. There's dusting and busting, irrigate here. And the busting is just a little lower joules, and the hertz are about the same. But what it does is it reduces the retropulsion, irrigate here. And if you reduce the retropulsion, you reduce some of that popcorn effect that you sometimes get. Am I on that now? Yeah. So I'm on the dusting now, which you can notice I'm getting good, like refined, like kind of fine granule stone fragments, easier to remove. But you notice there's less movement. I know there's some movement. You'll have some, but I'm saying that it'll be less movement and popcorn effect, which sometimes can help the stone, reduce the chance of stone like going into side branch or continuing to go up the duct. Now, urologists deal with this a bit more, and it gets more complicated for them because it could go up the ureter. The ureter is not as dilated of a system, and that apparently is a problem. So that's kind of what we're doing here. I think the laser stricturoplasty part is pretty much done. We are just going to get a wire. How much time do you have with me, Sachin?
I have a few minutes with you, Raj.
Okay. So then I think what we try to do is get the stone fragments to about under 3 millimeter. But we basically, we're decompressing the duct here. There's several mechanisms of pain in chronic pancreatitis, but I think we're going to talk about this at our talk. I think Dr. Easter is talking about PD stones tomorrow. But there's PD stones which cause ductal hypertension, and that's what we're trying to reduce is ductal hypertension theoretically. I'm sure it's much more complicated than that. We'll learn about that tomorrow. But we're just trying to fragment up the stones, and then we're going to gain access to the upstream. Oh my God, is that more stone there? Wait a minute. What's happening? Okay, so we have more stone here, but we're not going to be able to clear it all. But I think that, I don't know if that's still just fragmentation. Is it irrigate here? We didn't. Should we do it now? We could do it now. Okay, once the laser's out, we'll inject contrast through here instead of the cannula. And then I think, I don't think we need to balloon dilate this. I think I'm just going to use the laser. We did the stricturoplasty, irrigate here. We're going to get a 10 French wedge stent across this. And then if we're going to do balloon dilation later, we can do it the next time. I think it's sufficient. So what we're going to do here since we have a few minutes, why don't we get a 10? Let's see on fluoro how far away we are. Oh, so we're still just at the, just in the downstream body, would you say? Yeah, so downstream body, above the genu, and you have to have a really light foot with laser. You know, it's not like fluoro in your second year of fellowship. Like you have to, or your advanced year, like you have to really be prepared to get that foot off the pedal because the laser can slip, and you know that can, if you put a lot of pressure on the duct, even for a fraction of a second, and it's too much pressure, you will perforate the duct. Like don't be mistaken about that. So you have to be really careful that you're using just the tip of your foot and that you're willing to just come off the, like that. See that? You got to come off the pedal right away. There we go. Okay. So what I think we're gonna do now, I think this is good with laser, right? Let's do this, and then what we're gonna do, if you guys wanna hang around, I think what we're gonna do is we're gonna take the laser fiber out, and then we're gonna shoot some contrast. You can put on standby the laser. Oh, it's stuck again. It's stuck again. You don't wanna break it. There we go. Okay. And so we're gonna just inject some contrast. If you wanna stick around for the contrast to see the upstream duct, we can show you that, but it's entirely up to you, Sachin. Okay.
Yeah, Raj, we'll stick with you for 5 more
Okay.
minutes before Mihir's lecture.
Okay, I think you're stuck on this. Okay, so, oh, here's like, okay. So go ahead and, yep. Yeah,
Raj,
close
can I
that.
ask, if
So-
you get a stent across the area of stone blockage and you go to bring the patient back for pancreatoscopy and
Injecting it.
laser, but they did not note pain improvement with stenting, would you still proceed to stone fragmentation, or would you say that presumably
Inject
they
more?
might not respond pain-wise?
There we go. There's the upstream duct. Look at that. Yes, stop there. So this is a case of where, well, she was already getting some pain improvement with the stenting that wasn't even across the stone. Stop injecting there. And then we can just pass the wire through here, actually. Let's just do that. So take this off. Let's just flush contrast through here. So, I'm saline, sorry, flush it with saline. I think that that's a good point. I mean, in this case, I think that the pain will improve because it's partially already improved with limited, with stenting downstream of the stone. But I think, is your point that if the stent doesn't help the pain beyond, like if we get a 10 French stent across and her pain is no better, then you don't keep doing that. That's right. Now, sometimes I've had, stop there. I've had cases where you have large stone fragments and the stent is pushing up against those fragments and causing pressure on the duct. And then, so they can still have pain. So that's a possibility. I'd give them the benefit of the doubt. I try to clear the duct if possible. And then, of course, if they're still not improved in pain, then you go to the neuropathic type of medication. I don't know if that's the question you were, if I answered the question you asked.
Yes, thank you.
Here. Actually, still. Okay, so we're just going to get the wire up. Someone may ask about balloons to try to remove these fragments. I think that's a bit futile right now. It's high up in the duct. I think what we do is there's swelling, edema. We get a stent in and bring the patient back. We use a basket, probably. I would use a lithotripter basket, like a 1.5 centimeter, to drag it just in case you get the basket stuck. Irrigate here. I don't think we would need to do SPY again, but here we go. Stop here.
Can you comment, Raj, on the flow rate you use for the saline irrigation when you're doing?
There we go. So we got the wire up there. See that? You see that on fluoro? Good. It's up there. All right, so I'm going to give you the flow rate. So when I'm in the PD, I tend to reduce the irrigation force. But just we're at 60.
Hey, Raj.
We're 60%. Yeah, exchange here.
Raj, if it's okay with you, we'd like to move to Dr. Athman's room for a couple of minutes, and we'll be right back.
Okay.
Thank you. Hey, Mohammed.
All right. Hello. Hi. So right now we did the resection. I know it is not ready. I do better job than that, but actually it was a situation wherein it was tough lesion. As long as we don't have a perforation, we're good. But we do have a little bit of muscle injury at 1 o'clock. I would define it as a grade 2 out of 5 of muscle injury. But overall, we're doing good and insufflating the stomach. So now I would like to show the closure. And in retroflexion, closure with clips is very. We're trying a knob called that clip for closure, and it has 2 arms, and each arm has a different color. It doesn't rotate, so forgive me that I'm not rotating it. We'll start from this side. Let's open the gold part of the clip. Yeah, so now we'll put it in the healthy tissue in the margin here, close. And now we'll take this side. The lesion is very friable. Let's get open again, the gold bar. So I opened it because even trying to close it, the part is so friable that doesn't want to close. So try to get some part that's not friable, close here.
So
And
Mohammed,
we'll move it.
Mohammed, this clip requires a therapeutic channel. Did you change your scope to a 1T scope?
Yeah, we are using 1T scope now. Let's open the silver side. So yes, I forgot to mention that if you're using Olympus, close now. Deploy. So it got this part here, but the problem with this area is friable. We'll need another one to get to the other side. Yeah, we'll try another that clip. So as you can see here, the gastric wall is not that strong, but at least it approximated the edges. And this area is not easy to close in general. And the other option would be suturing would be hard too. So it will be X-tack. This will be something else that we can consider. But we'll try that clip, another one. And we'll see if we can close it. The other option is that for that area here, to avoid making bridge, we can put a third clip, something like.
Mohammed, while you're waiting, waiting for the clip to come, can you please focus a little bit more on the muscle defect? I would like the trainees to take a closer look.
Yes, and in this area here, sure. So we can see here that we have a still submucosa in this part. It's totally, what we are seeing, the part here is even muscularis mucosa, and the submucosa is the white part down here. So that's one here, and even some mucosa up there. So this very superficial cut, because this is EMR, not ESD. Up here, the muscle we're seeing is muscularis mucosa, and down here, that's the submucosa, the dense white fibers. So we had an injury on that side where I covered, and that's why I wanted to cover that part first. But here I feel like I don't see. Do you see, Sachin, something that you would like to tell me about? Maybe I'm
No. I don't see a through and through defect either.
Right, Mohammed, I was about to say that this all looks like just scarred submucosal tissue, and probably the area that you've covered might have had that small area, but we are not able to appreciate it in what we see right now. So I think
maybe
it's
right.
Right there at 3 o'clock, I think we're seeing a little bit of the splayed circular,
Yes,
but
that's
it's
the-
not,
yes.
I don't see it through and through per se, but,
Yeah, that's the one. That's the muscle injury is here exactly.
Yeah.
So
But it's not
Mohammed,
that big.
Mohammed, in terms of, I completely agree with closing the defect based on what you've seen. Can you just tell us what else you're doing for patient management? Are you inclined to giving IV antibiotics? Are you planning on keeping this patient overnight? What are you already thinking and telling your nurses?
Yes, so we give Levaquin, and we also going to admit the patient for observation for 24 hours. And it's not because of perforation, it's for post-resection syndrome. We use a lot of cautery in a very sensitive area, and if he stay in the hospital, have IV fluid and antibiotic, he will have better outcome than just sending him home, especially he is from 4 hours. So it's so interesting that the patient here referred from far away, which like in this situation, you really have to think twice before sending them home after complex procedure. So open the silver one now. We'll go to this area, close. My challenge here is that position of the endoscope that is not going all the way where I want it to go, but we'll try to do it. Let's open the gold part. Close. Deploy. So it's a very neat way of closing, and it requires even way less clips than the regular method. For the small area here, we're going to use Instinct Plus clip to close that defect, and that will consider, if I do the third clip, we'll have a complete closure. So closure versus no closure is not only for bleeding, but also for post-pulpectomy syndrome. And I worry more, the more I do of these cases, and I use a cautery, especially when you do EMR, and you do like deep resection like that, you worry about post-resection syndrome. So closure protect against that. So let's rotate it to 1 to 7, 1 to 7.
So Mohammed, we talked about these larger clips the last time, and I think we all felt that these are great approximators, meaning they may not close the defect and seal it, but they just bring the tissue close enough, and then you can apply other clips. Is that your strategy here, where you're going to now place more regular clips to kind of seal it?
Yes, you know, here we're speaking the same language. I use a word approximator exactly. So they approximate the edge and make other clips work better. And that's exactly what I'm doing now. So now let's close slowly, close, 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 close. All right, deploy.
And this is working very well. And for the trainees here in a retroflex position to be placing all these clips, one is it's technically challenging, and Dr. Othman's doing a great job there, but also the clips sometimes don't do what they are supposed to do once they're U-turned on themselves. So that's another, tricky part of it, but this is going really well.
So we can maybe put another one down here, another clip. Yeah, to close this defect, and we'll be done once we put the fourth one. But yes, tissue approximation here was a challenge, especially in the stomach. The stomach wall doesn't move that easily. In the colon, you can get by with any clip approximating the areas, but in the stomach, it is really hard.
What type of clip are you using now?
So we're using Instinct Plus clip, open. 1 to 7. So it's very important to be perpendicular on the line of closure. So that's why I'm choosing 1 to 7 here. Close. Close more. All right. I think that's good here. But I feel like once I put this, I might need another one. But let's deploy it. Yes. So I would rather put more clip than have bleeding later on. But you can argue things that's enough, Mohammed. But what do you think, Mayor and Sachin?
So I think that it may not be as tightly closed as to seal a perforation, but it has there's some space there. So I would keep going till you think that it's technically getting difficult to do it, because the more you close the stomach, the better it is.
Yeah, and what's happening, it ripped open one of the clips because of how this area is very friable and with insufflation. But I would rather see this now than go out in 5 minutes, it open up, open again. Yeah. And as Mahir said, in retroflexion, to do that is not that easy.
For the trainees,
All
if
right,
this
let's
hasn't
close
been
again.
said enough number of times, this is probably one of the toughest areas to close during an upper endoscopy. So a lot of credit to Dr. Othman, and of course to two of our best nurses, Lula and Summer, in the room.
Another one. Yeah, they are doing great. Actually, they're making me look good. Let's get another quick clip. So I'm slowly closing it from the edge. I still have this part here, and I will do my best. I always, Dr. Dostat would say, any closure better than no closure, especially in tough location like that, close to the junctions, upper esophageal junction. So I will get another one around that area. What happened that clip closed the area, but the mucosa could not tolerate the strength of the closure, and it opened up. That's what, open again. This time we'll go, yes, exactly, perfect, 11 to 5. And we'll try to go in between these clips. And this one, it gets even harder. All right, now we are there.
So
in between
again,
there.
this, the control of the
Hold,
scope in
hold
this
it.
position is
Hold,
very
hold.
impressive, and he's making this look very easy.
Close. Beautiful, deploy. Great job. All right, let's assess if we need. I think I closed it now, except maybe the area up here that I wanted one clip for in the other side. So let's get one more clip. I'm sorry, I'm a little bit.
Mohammed, just when I was about to say that there's no more room to put any more clips, you said you're going to put one more.
Just one in between the right side, between number 1 and number 2 from the right.
Yeah, I
That's good.
agree. I think once there's so many clips, it's difficult to assess, but we were saying, Vani and I were talking earlier, like if you think about an extra clip, then you should put it.
Yeah.
Yes. Open. So let's go 12 to 6, exactly. All right, great. All right, I think it is either between 2 and 3, not 1 and 2. Yeah, I might need someone to help me pushing it in this position. So actually, I still have to go up like that. Yeah, but do not push yet. Yes. Yes, now. Now try to close. Actually, I open again. Yeah, commit both sides. And so I will have to go to this way a little bit. Yeah, but I will, we don't need to push it yet. Because I will have to get, it's very hard, but we'll get it done. Close. Nice, deployed it. It's okay, you did a great job. All right, I think that's enough. I'm not gonna close more than that.
Looks great.
Mohammed, fantastic job. Congratulations to you and the entire team in the room. We're now going to
Thanks.
move to just one color forward.